Okay, so now we have a patient who is tachycardic. They have a heart rate over 100. It is not SVTs because the heart rate is not greater than 150. And there is clearly P waves right on the EKG strip. Your patient is symptomatic. They may be displaying some cardiac symptoms. They may tell you they feel their heart racing. Now let's talk about the causes, because in tachycardia, we have a rule. We treat the cause. So we have to know what the cause is. And now I'm going to take you through some, like one by one, some different causes. Probably one of the number one causes is going to be that fever or infection, and God forbid, sepsis. Now let's make sure we're clear about fever, infection, and sepsis. Fever could be inflammation, could be infection, could be any number of things, including thyroid and everything else. But let's just roll with the typical cause of infection. So if we're saying we treat the cause, then we would treat infection with antibiotics after blood cultures ×2 and a workup, right? Now, that was easy. That's probably the number one reason why your patient is tachycardic. So would that be extreme tachycardia? Not typically, but it would be tachycardia all the same. Let's look at another cause for tachycardia. I know it sounds weird, but I swear, anxiety is a really big reason for tachycardia. Panic attacks, you know, that sort of thing. Well, that's easy. We can either coach the patient to do some breathing exercises or recognize it for what it is in the short time we have and slide that patient some Ativan, right? Okay, so we're getting together here on this treat the cause. Let's move on. Let's say that in this case, your patient's cause is hemorrhaging. Ooh, who is that? You better be looking at that post-op patient first. The post-op patient who's tachycardic should be quite concerning, or the patient coming in with abdominal pain who is tachycardic should be extremely concerning, because those patients are probably hemorrhaging, either from the surgery in the first instance or from the abdomen in some kind of way, shape, or form in the second instance. And I'll tell you someone who you should be thinking of GI bleed when they're tachycardic. Liver patients. Liver patients, yeah, cirrhosis, you know, alcoholics. They're at such high risk for a GI bleed because of ulcers and different things going on in their GI system that you better be like on alert for them. So you get this alcoholic and they come in and they're tachycardic and they're complaining through slurred speech that their stomach hurts. Well, ding, 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 GI bleed? Maybe. Now, we know that quite a few shocks also have tachycardia as one of their symptoms. We know hypovolemic shock, for example, is definitely going to be tachycardic first. We also know that a patient with cardiogenic shock, septic shock, and almost all shocks, but not exactly all shocks, most shocks have tachycardia as their issue. One shock that does not have tachycardia as its issue is neurogenic shock, aka spinal shock. So don't let me hear that you go, oh, all shock has low blood pressure and tachycardia. No, that's not exactly true. But our patients who are in hypovolemic shock, or at least sliding that way, or going into septic shock would definitely be tachycardic. Now, this is a good time to point out so that my students and the team here are very savvy about sepsis. Just what is the difference between infection and sepsis? Blood pressure. Because sepsis, infection, fever of any sort from inflammation, all three of those are tachy. But the deal is, you know your patient is sliding into sepsis if their blood pressure drops. Hope you got that, because we got more coming up.